Good afternoon, everyone. Thank you so much, Abhida ma'am. Myself, Dr. Ashutosh Verma. I'm senior resident and FNP training in pediatric hemato-oncology in the Department of Pediatrics. So today I'll be talking in brief about the recent advances in immune thrombocytopenia. So I would like to start here with the case. A 2-year female presented in pediatric emergency with complaints of petechial rashes and melena since one day. There was no history of fever or joint pain or lymphadenopathy or any excessive irritability. The past history and family history were unremarkable. On examination, she was hemodynamically stable. The pallor, icterus, cyanosis, clubbing, and lymphadenopathy were absent. There were no dysmorphic features. And on systemic examination, it was normal. The only finding was isolated thrombocytopenia in the CBC. There were no immature cells, there were no dysplastic cells, there were no WBC inclusions, there were no micro or macrothrombocytes or any cystocytes in the peripheral smear. The coagulation profile was also normal. So I would like to ask the residents, can you tell the diagnosis here? I will come to it later. So what is immune thrombocytopenia? So it was previously known as idiopathic thrombocytopenic purpura, but now the terminology has changed to immune thrombocytopenia because it is no more idiopathic and not all the patients are purpuric. So ITP is an immune-mediated acquired hemorrhagic disorder of adults and children characterized by transient or persistent thrombocytopenia. The cutoff of platelet count should be taken as 1 lakh. So there are two types of ITP, primary and secondary. Primary, it is an autoimmune disorder. It is characterized by isolated thrombocytopenia in absence of other causes or disorders that may be associated with thrombocytopenia. So basically, it's a diagnosis of exclusion. Secondary ITP is all other forms of immune thrombocytopenia except primary ITP, like HIV-induced secondary ITP, drug-induced secondary ITP, malignancy-induced secondary ITP. So these are the common causes of the secondary ITP, like SLE, antiphospholipid antibody syndrome, common variable immunodeficiency, leukemias, EVANS, autoimmune lymphoproliferative syndrome, HIV, hepatitis C, Helicobacter pylori, post-vaccine, and post-systemic infection. Coming to the phases of disease, it is that newly diagnosed ITP is within 3 months from diagnosis. Persistent ITP is between 3 to 12 months from diagnosis, and chronic ITP is lasting for more than 12 months. So coming to this slide, this is the pathogenesis, and it is very important for us to understand the pathogenesis and also to understand the mechanism of action of drugs which are used in the ITP. So the first thing is autoantibody production. This is the autoantibody production. The platelet autoantigen, the glycopeptides in the platelet autoantigen, they stimulate B cells to produce antibodies. Secondly, these antigen are processed by antigen presenting cells and they reactivate the autoreactive T cells. The T cells further stimulate T helper cell, T helper 1 and T helper 17, and through CD40 ligand they stimulate autoreactive B cells, and they again form antibodies. This is the majority of antibody production which is occurring. This is the majority of mechanism. But there is one other mechanism, that is cytotoxic damage of platelets, which is occur directly without a formation of antibodies. And this explains why 20 to 30% of ITP patients you don't find any antibodies, any anti-platelet antibodies, because it is mediated by cytotoxic T cell. Second is increased platelet removal. So these antibodies, when they are formed, they react with glycoprotein 2B3A present on the platelets, and this antigen antibody complex further reacts with the FC receptor present on the phagocyte, and via splenic tyrosine kinase it goes under phagocytosis. If the affinity is very high, they can also stimulate complement, and complement gate lysis can occur, and also complement can cause further coating by C3b, and it causes opsonization, as already explained by ma'am. The third mechanism is reduced platelet production. So these antibodies are also produced against the megakaryocytes. So these, when they bond with the megakaryocyte, they causes decreased maturation, they causes phagocytosis or apoptosis. So the drugs which are used in the treatment of ITP, like first line drugs like steroids, IVIG, anti-D, so they act, and all the drugs, they act for this pathogenesis only. Like steroids, they blunt the response of T helper cells, they inhibit the antibody production, they also inhibit this antigen antibody complex to binding the FC receptor. Secondly, IVIG, they bound with this FC receptor and causes the blockage of the receptor, and also it causes down regulation of the FC receptor. Third is anti-D, it the RH antigen present the RBC. This anti-D binds on this RBC antigen, and this antigen antibody complex further reacts with FC receptor, and it goes phagocytosis or intravascular hemolysis by complementary pathway. The third is the second line of drug, like TP receptor agonist. The TP receptor agonist, they act on the megakaryocytes. They proliferate the megakaryocyte, and thus more platelets are produced. Second is the rituximab. Rituximab causes destruction of the B cells, and the B cells are destroyed, so no antibodies produced. Third is the splenectomy. As you know, this all these things are predominantly occurring in spleen. That these autoreactive B cells formation, the class switching of the IgM to IgG, and also this phagocytosis. This is mainly occurring in spleen macrophages. So splenectomy is another modality of the treatment. The third modality, that is the immunosuppressant. They causes inhibition of T cells and B cells. And the newer agents like fostamatinib, they cause inhibition of this tyrosine kinase. And ruxolitinib, it causes the antibody blockage of FC receptor. So this is how this whole mechanism is there, and all the drugs which acts on this in ITP patient. So to come to a diagnosis, we should first get a detailed history. The detailed history should be like onset, progression, duration, the type of bleeding, the severity of bleeding, any inciting event was there or not, like recent history of vaccination, any sepsis, any immunization. Second, the clinical examination. On clinical examination, we should rule out the stigmata of any malignant disease such as hepatosplenomegaly or lymphadenopathy, or there are congenital thrombocytopenia like TAR, thrombosis associated with the absent radius, a megakaryocytic radioulnar synostosis. In this, the physical findings will be like absent radius, radioulnar synostosis. On the CBC, you will find mostly isolated thrombocytopenia, and peripheral there will be megathrombocytes. But you have to exclude the other abnormal cells, like in Bernard-Soulier, these megathrombocytes are very big. They are even bigger than the shape of the RBCs. In May-Heglin anomaly, that in all MYH19 anomalies like May-Heglin, Festner disease, Sebastian disease, Alport syndrome, all these have very large platelets. They are megathrombocytes, but they also have WBC inclusion. So that should be ruled out on the peripheral smear. Third is acute leukemia, like blast cell we have to rule out. And for MDS, we have to rule out any subtle changes in the platelets, any dysplastic change in the platelets we have to rule out, and cystocytes to rule out HUS and TTP. Coming to the bone marrow examination. So bone marrow examination. So the American Society of Hematology, the ICE guidelines suggest that in a patient of newly diagnosed primary ITP, there is no role of bone marrow examination. But it is obviously essential in presence of anemia, which is disproportionate to the degree of bleeding, any abnormalities of WBC count, if the patient is presenting with fever, bone pain, or joint pain, or if you find a systemically unwell child, or there is significant lymphadenopathy or hepatosplenomegaly. So I would like to ask a question to you. If a child comes to you and you are diagnosing the child as a newly diagnosed primary ITP, so will you go and do a bone marrow in this child, and the child is presenting with you to you with bleeding? So this question is open to all. So please kindly answer this in a chat box. Will you go for bone marrow examination or not in this patient? I will come to it later. So the goal of all treatment strategy is to achieve a platelet count that is associated with the adequate hemostasis rather than a normal platelet count. And the second goal is to prevent serious bleeding, especially intracranial hemorrhage. Now the big question is, who should be treated? So as in his recommendation 2019 clearly says that children with no or minor bleeding, we should not treat. We should always keep the child on observation. We should not give corticosteroid or IVIG or NTD. And if we are keeping the child on observation, the parental counseling and general advice is very important. Like we have to explain the natural course of disease. Like 80% of the primary disease will go in remission, spontaneous remission. We don't have to treat at all. Irrespective of treatment, they will go in remission. Those 20% will go in towards a chronicity. The 50% will go in remission. Only 5% of the ITP children will bleed, and less than 1% of the ITP children bleeds significantly. Second is that they have to be told that they should not change the platelet counts. Third, anti-platelet drugs should be avoided. There should be limitation of activity that may cause head injury, that sports activity, all those which might lead to head injury. But regular jogging and regular playing should be there. It should not be restricted. We should also tell them to prevent the constipation, to give the high fiber diet food, and danger signs should be explained. They should know when to come to a hospital, and this should be a 24-hour hospital. So, in non-life-threatening mucosal bleed or diminished health-related quality of life, as guidelines suggest that there should be short course of corticosteroid rather than IVIG and IVIG rather than NTD. That means we should use short course of corticosteroid in case of non-life-threatening mucosal bleed over IVIG and IVIG over NTD. No, why it is so? The short course of corticosteroid such as prednisolone at 4 mg per kg for 5 to 7 days, it does not cause any significant side effect and cause remission in 5 to 7 days. Secondly, it is given orally, so the compliance is good. Secondly, it's not that costly, but IVIG, it is really costly as compared to steroids. It also comes with a black box warning of acute renal failure. So these drugs should be monitored. So, and NTD. So what are the prerequisites for NTD? There are so many prerequisites for NTD. Like the hemoglobin should not be less than 9 gram per DL. The patient should be Rh positive. The patient should not have been splenectomized, and he should be DAT negative. So in all the scenario, we can give NTD. So NTD is least preferred. So first, we should be short course of corticosteroid, then IVIG, and then NTD. So how to approach a child of ITP who is bleeding? So first of all, we should assess the severity of bleeding. There are many gradings of the bleeding like WHO, Buchanan, IVLS, but the most commonly used is the WHO. So there are 4 grades now: grade 1, grade 2, grade 3, and grade 4. Grade 1 and grade 2 are the skin bleeds. Grade 3 and grade 4 are the mucosal bleeds. Now grade 3 is mucosal bleed that doesn't require immediate medical attention. Example, a brief episode of epistaxis, gum bleed. But severe is like a mucosal bleed requiring immediate medical attention, like pulmonary bleed, GI bleed, uncontrolled or prolonged epistaxis. And life-threatening bleed is any bleed which is causing hemodynamic instability or there is ICH. It comes from the life-threatening bleeding. So, first of all, you have to assess the severity of bleeding. If it comes to the severe grade, that is grade 4, then you have to see is there any life-threatening condition or not. If the bleeding is under life-threatening condition, like the patient is having hemodynamic instability or the patient is having ICH, we should treat. The treatment includes all the following, like platelet transfusion, the rapid and sometimes continuous platelet transfusion is also advocated in this patient. IV methylprednisolone is given at the dose of 30 mg per kg for 5 to 7 days. IVIG at dose of 0.8 to 1 gram per kg is given over 1 or 2 days, or plus or minus NTD. NTD can be given or cannot be given depending on the scenario. If the hemoglobin is there, we can give it. If the hemoglobin is less than 9, we cannot give it. And if it is refractory to all this treatment, we should go for emergency splenectomy. It can also be tried. But the recent guidelines, which are still not approved, but it has come, but it's being used off label, is TP receptor agonist romiflostim. Romiflostim, it has been used to not to increase the platelet count immediately, but to sustain the increased platelet count. Second, if there is no life-threatening bleeding condition, then the treatment includes. Okay. So the treatment includes either or both of the following, like IVIG or NTD or methylprednisolone, or both, either IVIG or methylprednisolone. So if the patient is coming with non-severe grade bleeding, like grade 1 to 3, then we have to assess that is the patient at moderate to high risk of bleeding complications. Like what are these complications? Like head trauma without ICH, severe unexplained headache, planned surgery or procedure that is likely to induce blood loss, grade 3 bleeding, platelet if the platelet count is in 30,000 and the child has any of these following things, like he on antiplatelets, he on anticoagulants, or he having concomitant bleeding disorder like von Willebrand type 2 or platelet type von Willebrand factor, or close monitoring or follow-up is not possible. In all these cases, we should treat this child. So the treatment further depends upon that is there a rapid increase in platelet count is desired or not. Like in cases of urgent surgery or head trauma, if the rapid increase in platelet count is desired, then we should treat with IVIG or NTD or methylprednisolone. But if the rapid count platelet count is not desired, then we can treat with oral glucocorticoids. Bleeding, like grade 1 and 2 skin bleed who do not have a moderate to high risk for bleeding complication, pharmacotherapy is not indicated. So the recommended evaluation in who are going to be persistent or chronic ITP. First, we should review our diagnosis. Second, we should rule out the inherited thrombocytopenia. Third, we should review the medication, common medication sometimes like valproate can also cause thrombocytopenia, which should be missed on routine examination. Bone marrow evaluation should be done if it not be done earlier, and test to identify infections such as HIV, H. pylori. The role of next generation sequencing, which I will discuss later. These are the common tests which should be employed in the case of secondary ITP, like DAT and ANA, syndrome, other autoimmune disorder or rheumatological disorder, antiphospholipid antibodies in case of and quantitative immunoglobulin in case of hemoglobin deficiency, flow cytometry for double negative T cells in case of affecting ALPS. Coming back to the case A, we had that patient who was having petechiae and melena. She was otherwise she was normal, but she had isolated thrombocytopenia. So she was diagnosed as newly diagnosed primary ITP, and she was further managed with IVIG. Further, she improved and she was in remission till 6 months. After that, she again presented in emergency room with severe GI bleeding, with hemodynamic instability and altered sensorium. At this time, she was in severe pallor, multiple significant lymphadenopathy were present, and she was also having hepatosplenomegaly. The CBC was showing anemia and thrombocytopenia, but there were no blast cells, no dysplastic cells, and direct antiglobulin test was positive. The negative. So now, how will you manage? So as this is an emergency.
Sorry to interrupt. I would request everybody to mute yourself. Dr. Khushbu, Dr. Neeraj.
So she was, as this is an emergency condition, so she was managed with platelet and PRBC transfusion with IV steroid and IVIG. But she didn't respond to this also. So finally, emergency splenectomy was done. Bone marrow done at that time showed normoblastic erythroid hyperplasia and reduced platelet count with giant megakaryocytes. Lymph node biopsy was reported as follicular hyperplasia. So what are your differential diagnoses at this time? Is it Evans syndrome, anemia, thrombocytopenia, DAT positive? Yes, if it is Evans syndrome, then secondary to what? It could be because of immunodeficiency, it could be because of ALPS. So we did an immunoglobulin profile. It showed increased IgG levels and other were normal. And the flow cytometry done was suggestive of double negative T cells positive, that is more than 3%. So diagnosis of autoimmune lymphoproliferative syndrome was made. So what is the role of genetic testing or NGS in this condition? So whenever we are coming to diagnosis of like flow cytometry for double negative T cells is positive, so we have to confirm the diagnosis. So to confirm the diagnosis, we should go for genetic testing. The genetic testings like the mutations in the germline or somatic mutations in FAS ligand or Caspase-10 are there in ALPS. And to rule out other ALPS-like disorder, like ALPS-like disorder may present like same with same clinical feature, just like ALPS only, but the mutations are different. Like they have ALPS-like disorder have a mutation in CTLA4, LABA or LRBA or FADD. So these are quite different from the mutations which you get in the ALPS. So to rule out ALPS, we have to do the genetic testing. To do the family screening, if you find germline mutation, then you have to do the family screening. You have to counsel the parents regarding the future babies and all. Rule out thrombocytopenias and for prognosis. Why for prognosis? So they are like in ALPS only. Like in ALPS only, this the mutations, the locus of genetic mutations really carries a lot of importance. Like if it is in the intercellular region of the FAS region, so this carries a worst prognosis. You know that your treatment is not going to work. So we'll counsel the patient for hematopoietic stem cell transplantation. So treatment in chronic ITP, again, if the child is not bleeding, we should observe, because we know that more than 50% of the child will go in remission. If there is acute episode of bleeding, then you should go for the first line therapy, that is steroid, IVIG, or anti-D. If it is not responding to the first line therapy and the child is bleeding, diminished quality of life, then you should go for second line of therapy, that is rituximab, TP receptor antibodies, or splenectomy. And then third line is immunosuppressant and cytotoxic agents. So coming to the rituximab, so rituximab is anti-CD20 monoclonal antibody. The mechanism of action is it destroys CD20 B lymphocytes, which are assumed to produce autoantibody. Low dose of rituximab is also found to be useful, like 100 mg per week for 4 weeks. But the usual dose is 375 mg per meter square 4 weekly for 4 to 5 months. The response in chronic ITP is around 30 to 70%. So the side effects usually they are very minor infusion-related side effects, but it might cause serum sickness. It might lead to the activation of JC virus, causing progressive multifocal leukoencephalopathy. So what is the role of rituximab in the treatment of immune thrombocytopenia? So the journal Hematologica, they had studied the use of rituximab for chronic ITP in children. So all the recent big studies were evaluated, and they found that rituximab has been found to induce the remission in quite good number of patients, but the long-term and sustained remission is lacking. Second important thing is that we should ascertain the underlying cause of secondary ITP when planning to rituximab, because like in SLE or in other in autoimmunity like Evans syndrome, which is secondary to SLE, the rituximab is maybe preferred. But in patients with ALPS or CVID, rituximabs are avoided because it causes severe hypogammaglobulinemia and so ascertaining the underlying cause of secondary ITP is critical when planning to use rituximab therapy for refractory diseases. Like I already told that it is preferred in patients with SLE or with Evans syndrome, but in ALPS patient and in patient with CVID, rituximab should be avoided because it causes hypogammaglobulinemia and serious life-threatening infections. It also leads to reactivation of the hepatitis B virus infection. So the coming to the next agent, that is thrombopoietin agonist. So the mechanism of action is it acts by production of by stimulating the CMPL receptor. Initially used with the recombinant human TPO and pegylated recombinant human megakaryocyte growth and development factor. Now the second generation TPO are they don't have any sequence homology to endogenous TPO. They are romiplastim and eltrombopag. So the coming to the mechanism of action. So this is the cytoplasm of megakaryocyte. This is the cell membrane, and this is CMPL ligand. So romiplastim acts on the CMPL ligand, and eltrombopag and abatromopag they acts on the juxtamembrane part of this ligand, and through this they stimulate the JAK pathway, and through JAK and STAT3 pathway the further causes increased megakaryocyte proliferation and differentiation, and thus the platelet count increases. The adverse effects usually encountered are headache, especially with romiplastim, fatigue, and insomnia. Development of bone marrow reticulin, that is myelofibrosis, is also seen with both the drugs, but they are reversible. TPO receptor agonists have also been associated with thromboembolic events, but these events are very rare in children. But we should know the risk factors, like any past history of thromboembolism, obesity, or OCP. Eltrombopag causes transaminitis and also causes iron deficiency anemia because it chelates iron. So there were some articles like the extent study. It was a phase 3 open label long-term extension study of the safety, tolerability, and efficacy of eltrombopag in patients with ITP of at least 6 to 12 months duration who had completed previous eltrombopag study. So briefly, I will tell the study design. So eltrombopag was initiated at 50 mg OD, adjusted to keep platelet count more than 50,000. And second thing was to reduce the concomitant ITP medication, keeping platelet count above 50,000. Third thing was to identify the minimal dose to maintain the platelet count above 50,000 with or without minimal concomitant medication. And fourth is the evaluation of safety and efficacy of long-term dosing with or without minimal concomitant medication. So after this study, they interpreted that eltrombopag increased platelet count in most patients with ITP in a consistent fashion to adequate levels. It was well tolerated and appeared safe with low frequency of severe adverse effects such as bone marrow fibrosis. There was another study published in Lancet 2008 about the efficacy of romiplastim. It was a double-blind randomized control trial. They also had a similar interpretation that romiplastim was well tolerated and it increased and maintained platelet counts in splenectomized and non-splenectomized patients with ITP. And many patients were able to reduce or discontinue other ITP medications. After these studies in adult, there were clinical trials in children. The largest of two were by Bussert et al. And Grinder et al. The Bussert et al. Is a petit study. It is a three-part, multicentric, randomized, placebo-controlled trial. And they also had come to the conclusion that eltrombopag was the remission rate in eltrombopag was significantly higher than the placebo arm. Like the primary endpoint was reached significantly higher in eltrombopag in both the study, in petit and petit 2. Similarly, romiplostim, the clinical trials in romiplostim, they also came to the same conclusion that the romiplostim was associated with a higher remission rate than placebo. So the eltrombopag was approved for use in children with chronic ITP in 2015, following two multi-centered double-blind placebo-controlled trials, that's petit and petit 2. And romiplostim was approved in December 2018 for use in children over 1 year of age with refractory disease, which is persisting more than 6 months. So coming to doses of eltrombopag, it is given per orally OD at a dose of 25 mg to 75 mg. And romiplostim, it is given subcutaneously weekly. The dose is 1 to 10 microgram per kg. This dose will be titrated based on the platelet count. We have to keep the minimal dose to keep the platelet count between 30 to 50,000. So which of these two of the agents should we choose? Like meta-analysis of these of the 5 RCTs had concluded that both drugs have similar efficacy. But so to choose between them, we have to see the compliance, adverse effect, the patient preference, and cost. So the eltrombopag, it comes with strict dietary restrictions. Like it should be given empty stomach, particularly it should be given 2 hours before and 4 hours after meal, which contains iron, calcium, or milk or other dairy products. If the patients have absorption problem or transaminated, it may be prudent to use romiplostim. And if the patient who do not come to the clinic every week for injection, then eltrombopag may be better. Cost is a big issue here because these drugs are very costly. A study was done in PGI Chandigarh where they had analyzed the cost of these drugs. They found that eltrombopag had costed around 1.6 lakh per month and romiplostim about 2/3 of that. So these drugs are really very costly. Now, how to deal with the non-responders? So if one TP receptor agonist doesn't work, switching to the other TP receptor agonist has been found to be very effective. And addition of a small dose of steroid like 2.5 to 5 mg of prednisolone has also been tried in non-responding patients. Other thrombopoietin receptor agonist agents are avatrombopag and azutrombopag. Avatrombopag, as I already discussed, it just acts just like the eltrombopag, but it does not have any dietary restrictions. And it also can be given in patients of chronic liver disease. But these have been approved in adult, and the clinical trials in pediatric patients are going on in 2021. Azutrombopag has not been approved for ITP. Other new agents like fostamatinib, I have already earlier that it is an inhibitor of spleen tyrosine kinase, and rozanolizumab is a blockers of FcRn, Fc receptor. But these all are the drugs which are being studied in adult and pediatric. The clinical trials are still awaited in pediatric patients. So what about splenectomy? It was earlier described in 1913 in ITP. The predictor of success were young age and the response to IVIG. The mortality rate was very low with laparoscopic procedure, but those who are not vaccinated in those patients, the risk of infection is around 50 to 70%. So the recent recommendations about splenectomy, and according to the ALPS 2019, is it is currently used for emergency bleeding control for its rapid and sustained response, and also being used with children with significant bleeding who are more than 5 years of age, who have tried and failed available medical management for 1 year, including combination therapies. And prior to surgery, the vaccination should be up to date with Haemophilus influenza type B, pneumococcal, and meningococcal. So this is summary basically of what we have learned till now. That the management of children with persistent and chronic ITP who do not respond to the first line treatment. So we should first, the ALPS guidelines suggest that we should first use TP receptor agonist over rituximab and rituximab over splenectomy. A word about third line therapy. So there's a paucity of evidence regarding this, the efficacy and side effect in pediatric patient. The agents commonly used are azathioprine, mercaptopurine, MMF, sirolimus, cyclophosphamide, cyclosporin A, dapsone. Dapsone has been used quite frequently in these patients because these drugs like rituximab and TP receptor especially, they are very costly. So dapsone has been used with quite a good success. Around 30 to 40% of research has been documented dapsone. Then danazol, vincalcloids, alemtuzumab. Alemtuzumab is anti-52 monoclonal antibody. It causes severe B cell and T cell depletion, so it poses a serious life-threatening risk of infections. Combination chemotherapy has also been tried, such as cyclophosphamide, prednisolone, vincristine, and at last, autologous stem cell transplantation has also been tried. So in all this, this initial response rate have been around 30 to 60%. So coming back to our case now, so our child was diagnosed as ALPS. She underwent splenectomy, and after that she was under remission for 1 year. So she presented 1 year later with pancytopenia and bleeding manifestation. So what is your next step in management? Can somebody write the answer? Sorry. Chat box. So we can't give rituximab. Here we can't give rituximab because the patient is ALPS patient, the patient is already splenectomized, and the patient is presenting with pancytopenia. So rituximab can cause hypogammaglobulinemia and cause severe life-threatening infection. TP receptor agonist, there has been no role of TP receptor agonist in ALPS syndrome. So the drugs like MMF, they have been found to be very useful, but the problem with MMF is that it do not treat the lymphadenopathy or splenomegaly. The splenomegaly doesn't reduce. But with sirolimus, in more than 90% of the patient, the splenomegaly regress, the lymphadenopathy regress. So the drug of choice is sirolimus in the patients of ALPS, but it can be given sirolimus plus MMF, MMF plus steroid. So depending on the combinations can be given. And what is the definitive treatment for her? So I've already told the definitive treatment is stem cell transplantation. This was all from my side. Thank you for your patient listening.
And thank you for updating us on the current managements in ITP.
Thank you,
if
ma'am.
the residents or any audience have any queries, they can ask in the chat box. Okay, so I believe there are no further queries. So we would end today's session. And we meet tomorrow again at 1 p.m. with another subspecialty, that is infections in pediatrics. Thank you so much, and hope that everybody joins us tomorrow again at the same time. Thank you. Thank you all the speakers and all the listeners.